Right. So thank you, the chair and the speaker, for making the time for us today. We welcome you back on this platform of the DY Patil Postgraduate Lecture Series. This is the second part of the talk that Dr. Bhaskar had started the last week on Thursday last. And as expected, it was not just interesting, but also quite stimulating. He threw up a lot of interesting perspectives and the challenges that we have at a clinical level as well as at the academic level. So he's going to take it forward today. To chair the session today, we have with us Dr. Sanjay Baro. He is a friend, an inspiration, and a very astute gentleman, very articulate, and I've enjoyed his bantering on various academic platforms. He has quite a mean, cynical streak at times, which you shall probably see through today. But of course, he's an excellent clinician. He has passed his MD in psychiatry from Baroda Medical College in 1991. He has been in practice at Gandhina at Kutch in Gujarat from 1995. And he is the first private psychiatrist of the Kutch district. So he is quite active on various academic platforms, as I mentioned earlier. And we are very happy to have him with us today to chair the session. And I invite Dr. Baro to take over the proceedings of the day. I'll come back to you at the end of the talk. Over to you, Dr. Baro.
Yeah, thank you, Rasmin. I have been given the task of introducing Bhaskar. Bhaskar doesn't require any introduction. And in the previous session, my colleague Dr. Naresh had introduced him, but still a short introduction. He is an avid student of psychiatry, and he is most comfortable in molecular biology. And for him, psychiatry is molecular psychiatry. And don't say psychiatry is biological, because that will get his goat. Another thing is special areas of interest are treatment resistance cases and transdiagnostic study in psychiatry. This is a short introduction of Bhaskar. Regarding the talk today, this is the second part of the talk. In the first part, initially to begin with, he exposed and mildly insulted all the forefathers of psychiatry. Then he drove directly into why DSM and ICD are useless, unscientific, not based on any neurobiological coordinates, and just it is just an a simple thing. There is nothing scientific about it. And lastly, he also tore into the RCTs regarding the treatment or the molecules, because he says that we don't know whether we are seeing the same patients or the same severity of the patients. So all those RCTs also might be useless. This was what was said in the last session, and he has destroyed the edifice. Now today in this session, hopefully he will show the way ahead, the roadmap, and how to get out of this mess. Over to you, Bhaskar. The floor is yours.
Thank you. And thank you for not introducing me. The thing is, I yesterday showed the magnitude of the problem. How much, pardon the language, how much deficit we are in. We are literally Asian stable. We don't know where to start. We don't know how much time it would take to clean the whole thing. And we don't even know the magnitude of the mess. That is why last talk was about what is totally wrong. In last talk, I also told you about all the names, that is depression, anxiety, OCD of today were invented in 1975 to 80 by a group of Kreplinian people, neo-Kreplinians. So standing there, all the diagnoses that we see today are made up by them. Only original diagnosis was major psychosis, and major psychosis was divided by Kraepelin into two groups. That is what we have as a disease. Rest of the thing, we don't have anything at all. So standing there, which is the way forward? I have tried to show you the magnitude of the problem. That this is how where we stand. We have only two real proven disease group, and rest are just names taken from normal person talking. A person says, I feel low mood, and neocrepilians has named that as depression. Similarly, anxiety and things like that. So standing there, we have to find some new thing to move forward, to give our subject the much needed scientific validity, scientific understanding, and ultimately give the scientific framework. So this would be our talk of today. I am sharing my screen. So this was the end of yesterday's lecture, where I have shown what are the deeper problem of real classification by behavioral addiction name. Now, what's the solution? The only solution can be of three types. One is going back to basics and start from zero. The other is keeping DSM or ICD and understanding they are useless scientifically. So side by side, improving scientific awareness, knowledge, and discarding the imaginary nosology one by one. And the third is what a few countries have started doing, which is a way of complete anarchy. But anyway, if we are talking about everything, anarchy is also one of the ways. That is rejecting DSM and ICD and create our own Indian system of nosological research, nosological entities, and biomedical integration. So let's start with going back to basics and starting from zero, because that is actually the most interesting way to understand brain. While a group of people were trying to create psychiatric nosology from nothing, at the same time in 1970, another group of people were trying to understand brain from anatomical and evolutionary perspective. MacLean is probably the most famous of them, but he certainly is not the only one. There are a lot of researchers in that group, and if anyone is interested, they can go to MacLean and search his references and his citing articles, and he would find all the name of these people. So what MacLean proposed that brain is actually a three-stage production. Means one is reptilian brain, which has basal ganglia, midbrain, and brainstem. It is the oldest part. It has the most resilience to anything, and it represents the reptilian part of animal evolution. Then came paleomammalia part. The paleomammalia part is common to all mammals, and it contains hippocampus, amygdala, and olfactory tubercles. This paleomammalian part is slightly more complex than protoreptilia part, and it adds to various higher functions. Then came neomammalian, which is anthropoid, ape, and other group representation. And here we develop neocortex. This MacLean's model, tripartite brain model, was rejected on the ground that during live examination of fetus development, it was found that all brain parts develop at a time. So there is no, so people concluded that there is no reason for brain to develop into three parts. No, it is not. But the idea has certain merits. For example, the proto-reptilian part has the least cellular layer in brain. Then that is followed by paleomammalian, and neomammalian part has most cellular layer. So some microscopically, these three are different region of brain. That is true. And from their functional organization, it too can be seen that one part of brain is related to basic life sustaining measure. Basal ganglia, midbrain, and brainstem would be that. Then basic socialization and basic environmental interaction is done by hippocampus, amygdala, and olfactory tubular. That is the paleomammalian part. And neocortex is needed for higher order social interaction and coordinated environmental response. So again, MacLean created a wrong model, but some of his observations do stand test of time. Now, then came Jack Panksepp. I am personally very much grateful to Jack Panksepp because when I joined psychiatry, I was bewildered. I couldn't understand why I have to read psychology, why I have to read phenomenology of SIMS, psychopathology, because if there is no mind, there is no pathology in mind. So why I have to read psychopathology book and other things? Then there was a book of Panksepp, textbook, sort of textbook of biological psychiatry. That actually was very good in the time of 2003, 2004. It gave a latest idea of brain research, and it gave desperate people like me a hope that no, it is a medical science. So standing there, I am actually grateful to Panksepp. Now, what Panksepp did on MacLean? Again, he took the MacLean model and he divided into network. Network means network for play, network for hello, network for play, network for network for seeking, network for lust, network for rage, network for fear, network for panic, and other. Now, this was a very primitive understanding of 1998, but it was in a very, I would say, bold attempt to integrate the MacLean model into observable phenotypes. And as you can see from the color-coded diagram, his model included all of MacLean, but it uses it in a integrated one. Play would contain neomammalian, paleomammalian, protoreptilia part. Care would contain same. Seeking would contain same. Fear, panic would contain more protoreptilia rather than neomammalia. But ultimately, all of these three are involved in them. Some have more, some have less. This concept model was later taken into account when the research domain criteria came into being. They actually took the concept network and divided into more. They divided into cognitive symptom, social processes, positive valence, negative valence, arousal and regulation. And if you think about it, then these RDoC actually represent a very refined form of MacLean model. Ultimately, MacLean model still forms the basis of it, as we can see via the color coding. A neo-mammalian part is now into cognitive system. Neo-mammalian part is also involved in social process, positive valence, negative valence, but it is not much involved in arousal and regulation, where the hippocampus, amygdala, olfactory debacle, they are involved in social process, positive valence, negative valence, arousal, but they are not much involved in cognitive system. Then basal ganglia, midbrain, brainstem, they are more involved in fear and panic, and here they are more involved in arousal, regulation, etc. This is again an imperfect model because again basal ganglia has response in cognitive system. That is why RDoC is now getting divided into behavioral endophenotype. Cognitive system is getting changed into cognitive control, working memory, declarative memory, language perception, attention, and each of them would contain all three systems. Then social processes would go into perception, understanding, social communication, then affiliation, then attachment, then vigilance, then positive valence would have various endophenotypes similarly. Negative valence would have various other endophenotypes. And ultimately, arousal and regulation too would have different endophenotype. That is how that the alternative system is progressing. And now there is a full-fledged guideline to transdiagnostic psychiatry. And that movement is slowly gaining strength. Unfortunately, when Thomas Insel actually was kicked out of NIH, RDoC and its further subclassification got a big blow, but slowly it is recovering from it. But don't think that RDoC is perfect because again, RDoC doesn't understand yet how different brain areas work and form these behavioral endophenotype. So this is one of area. We can throw down DSM and ICD and go from MacLean to concept to RDoC to behavioral endophenotype, and ultimately we might come up with a neurobiologically based psychiatric nosology or taxonomy. But there is some problem with this approach. The first problem is what do we do with the patients now? We cannot say to them that bhai tera kuch bhi nahi hai. You have a brain disease, but we don't know about any where it is, how it is. We don't have the actually technology to name your disease, but you have a disease and you need to get lifelong treated. It will be very hard to convince the patients. So a compromise is needed. This is the compromise. I am enlarging this slide because this slide is very slow. But first, say that different level of this slide. Here, we are keeping the names, but we are researching the things that are inside the name. First, we are looking into genetic, hormonal, subcortical, and environmental markers. Then we are going into emotional expression. Then we are searching negative, normative behavior, as well as the spectrum that would lead to syndromal expression. And finally, we are checking that to neuropsychological and ultimately clinical dysfunction. So this is the background that we are looking at. We are seeing neurohormonal influences, which can be seen via testosterone level, HPA axis function, as well as function of every hormonal axis. Then there would be environmental influences, traumatic brain injury, hypoxia, teratogen exposure. Then there is epigenetic regulation of receptor function, which is partly vulnerability, partly environmental, because epigenetic is ultimately controlled by genetics. Then vulnerability alleles, we have found DAT, DRD, ASLC, 6A4, CCN, A1C. Then there are direct genetic liability or burden, 18P 11.32, 16P 11.2, area CNV burden, and there would be de novo mutation, which that de novo mutation would cause disrupted neurodevelopment. All of them would create a subcortical endophenotype. Who should be the subcortical endophenotype? The blunted striatal response to incentive. What is blunted striatal response to incentive? Anything that changes in surrounding would have a expectation correlate from an animal's brain. The animal would either expect something from the environmental event or would want to avoid the environmental event. If the desired response is met, then that is incentive. Now, due to these gene environment changes, this expectation response would not be there, and there would be trait anhedonia irritability. Now, trait anhedonia irritability would lead to two types of behavior. Either it would lead to reward seeking, and that would turn into attention deficit trait, or there would be behavioral bias too. That is, the animal would start avoiding the stimulus and would show immobilization response, and that would lead to recurrent unipolar depression. So the same cortical phenotype can give rise to two types of behavior depending on final response. What would be the final response? The final response is the unipolar depression one also has strong amygdala reactivity to danger. If any of you remember your basics, you would remember that autism can be detected at 3 months by reduced baby response to mother, reduce social smile to mother, and reduce eye contact with mother. Now, this subcortical endophenotype of strong amygdala reactivity to danger has something to do with this. Because if amygdala is hyperactive and it is not adequately inhibited by ventromedial cortex, then there would be active avoidance of all type of stimuli that might harm the individual. So the individual would react very avoidantly towards any external stimuli, be it recognizing other members of society, be it interacting with them, be it holding eye to eye contact with them, because eye to eye contact is one form of social communication, and for higher degree animals, means anthropoid apes, macaw and other, it is one form, the strongest form of social contact. And whenever there is social contact, there is high level of threat sensitivity, and that needs to be dealt with. Since these people have high level of amygdala response to danger, they prefer to not engage with threat. They prefer to stay inside their structure, and so they do not socially respond to mother. They do not maintain eye contact, and that creates the first observable symptom of autism, or rather autism spectrum disorder. Now this trait, when it gets combined with fast phenotype, produces unipolar depression more. So you see that term unipolar depression is crisscrossed by multiple cognitive and multiple cortical as well as subcortical traits. Now, again, is that this sufficient to produce attention deficit and unipolar depression? No, it is not. There is another cortical endophenotype, that is prefrontal dysfunction. As I was talking about, inappropriate suppression of amygdala by ventromedial prefrontal cortex. If it is there, then the full picture would come, otherwise it not. So you can see that various cortical endophenotype and subcortical endophenotype combine to form the so-called symptom that we see. Many a time they are normative. This cortical endophenotype and this subcortical endophenotype might be there in a patient, but that doesn't mean the patient needs treatment. It is another problem. If the patient's functionality is maintained and patient is doing well, then in spite of this endophenotype, patient would manage to remain within normal functional domain, and that would be normative behavioral, that would not be syndromal. But if the functional deficit starts to appear, then it would go into attention deficit or unipolar depression, depending on various other indicators. So it is a very painstaking measure. It would take a long time. And ultimately, we might need to go into approach one in some areas, that is discarding everything. But this second approach has some benefit of giving patient a name. Yes, you have depression. We know there is no disease called depression, it's just a symptom. But for now, your symptom's name is depression. Tomorrow, this symptom might evolve into some other symptom like OCD, or some more other symptom like mania. But at present, what your symptom is depression. This is the second approach. We are telling the patient that the name is not a disease, it's just a symptom. But we are also telling the patient that it would evolve, it would change, And these are just expression of an underlying disease that might or might not be evident in the patient's lifetime. Now, where approach 1 and 2 would need combination, this depression tag is where we have to use approach 1. We have to discard the notion of depression, anxiety, because they are just made up name in 1970 to 80, and it would be extremely hard and impossible to find any neurobiological basis for this term, because they has a very expanded feeling with no real understanding. What is meant by depression by one person would mean something else by other person. Similarly, anxiety too is culpable of the same problem. It can mean anything and everything in different persons' description. So some names we can salvage. Psychosis, we can go via this approach too. Mania, we can go via approach 2. OCD, we can go via approach 2. But these various forms of anxiety and depression, there is no way to salvage them. The third, discarding DSM, ICD, and creating Indian system. This is actually going to create anarchy, but we have to understand that many of the Asian countries are now creating their own. We have to understand that many of the Asian countries have created their own diagnostic system. Chinese classification of mental disorder now in third edition, actually third R revision. Korea and Japan is diverging from ICD and DSM, and Japan has very old system of classification of psychiatric disease. Why not we? There are 1,000 causes that says why not we? Number one, country-specific diagnostic system means we are directly saying these systems has no meaning, because if you are in Japan, you are in hikikomori, and if you are in Australia, then you are in autism spectrum. That just means our basic communication and understanding in brain has failed. Otherwise, why should we start giving different names to same thing? Similarly, when one patient migrates from one country to another, it is a disastrous thing to undergo again re-evaluation and re-treatment procedure. So creating nationwide different psychiatric disorder classification is a bit very odd and regressive state, but not more regressive than DSM and ICD, which has almost no scientific basis. So I cannot, although it would create anarchy, although it would create a lot of problem for a lot of people, this is another way where many of the countries are working, and in future our country might work. So the take-home message. Take-home message is for PGTs only. It is not for any consultant. Although, unfortunately, today the attendance is very low. That means PGs are not attending. The take-home message would be you can commit and vomit DSM and ICD in MD examination. but standing is 2023 DSM and ICD has no diagnostic value. It is just prescription used for communication, insurance, and economic benefit. And we should keep it that way. We should not make it a life-changing stamp for patient. We are not here to stamp a patient as schizophrenia, bipolar, OCD, and destroy their life. Then there is another important point. Psychopharmacology should not be limited by imaginary nosology of DSM and ICD because these nosology are not scientific. So there is no use of naming a drug, antidepressant, antipsychotic, and so on. Brain doesn't work that way. Brain doesn't understand that way. And so there is no rule that you cannot write any drug in this because this is depression, and in depression you cannot use anything else except antidepressant. This is a foolish statement, and this limits our total psychopharmacology choices because ultimately so-called depression many a time benefit from low dose antipsychotic. So-called depression many a time benefit from anti-epileptic. So-called depression many a time benefit from attention enhancing molecule. So-called depression many a time benefit from benzodiazepines. So-called depression many a time benefit from any and every drug of pharmacology, not psychopharmacology. Any and every drug of pharmacology. Similarly, the same thing is true for psychosis and other. So standing there, limiting the drugs by this imaginary nosology is making us poorer clinician, poorer healer, and definitely worthless medicals. So we should stop limiting the psychopharmacology. Now the third point I have been elaborating for a long time. Evidence-based medicine doesn't exist in psychiatry. Just its forms are present without scientific validity and substance. Psychiatry has no data. We are dealing with 8.3 billion population of world, and none of our evidence base contain more than few thousand data. How can we call even a sub evidence? Our evidence base is predominantly white skin, predominantly urban, with no representation from any of the colored race, any of the poorer countries, poorer socioeconomic strata. So how can even we say that we do there is evidence-based psychiatry? Well, how can we even say that this guideline is evidence-based? All the guidelines are just produced by people who themselves decided that they are experts of this thing, and so they have created a guideline. Who says that Mosley is the best institute in world? Who says it? Any evidence? No. Who says that this is the best institute, this is the best doctor in psychiatry? Except self-promotion, nothing is real in psychiatry. Everyone is self-promoting and saying my model is best, my thing is best. Ultimately, this is model. Whenever you utter the word model, you lack validity and other thing. Any biomedical subject should have biology as its backbone, not model. So we should not limit present care with the baseless dictates of guideline, algorithm, which has no real world meaning. Take patients as an accomplice in their treatment process, make them a part of it. And then we should jointly progress in scientific logic-based discussion and logic-based treatment of patient with participation of patient and their relative in every state of it. With this, I am ending my presentation of today. I don't know how many are here. 20.
Thank you, Bhaskar, for the. Thank you, Bhaskar. It was quite a sobering lecture. We are still at the drawing board level. Still a long way to go. Just we are at the crossroads. I don't know which path we will take, but it was quite interesting. The alternative is quite real. Only thing is how to put it into clear terms and how to explain that to the patients and relatives. That is the difficult part at present. So, as you told, that the second option of at times sticking with the symptoms as diagnosis at present has to be followed as of now. Later on, as science progresses, when I, of course, will not be there, you, of course, will be there, and then we will see how it turns out. Yeah. Any questions from the audience, or are they too stunned by the new information given? Now, any questions are there? They can unmute themselves and ask the questions.
Yes. I have 10 minutes today for your question answering, because last time we could not give much time for question answer.
Yeah, any of the participants who want to ask questions can unmute themselves and ask Bhaskar.
Yes, do ask. I don't mind. I am not a teacher. I am just a senior student. So anyone can ask anything. I'll be just a senior student answering a junior student. That's all. And sometimes a junior student answering a senior student. Nobody.
I think, Bhaskar, they are really stunned by the scope of your lecture, and I don't think that they'll be able to digest it immediately. Even I have difficulties in grasping it all. As standing up as of now, because what to tell the patients, the relatives, that question always remains, because mostly
Yes.
every educated patient will ask, Doctor Saab, kya hai mujhe? So we cannot tell him that you have something which I don't know and which is likely to change. So then we'll say that आप ही पागल लगते हो.
यही बोलेगा. But that is the truth of psychiatry today. And in establishing DSM and ICD as the Holy Bible, we have forgotten that this Bible has no basis. There is no scientific basis of this too.
We have a comment from Dr. Jaya Jacob. It is something that we have to think.
It is something we have to think and find out about.
Right. If
I have actually. Yes.
Yeah.
Sure.
So yeah, you've said that, clearly the Chinese are moving away, the Japanese and the Koreans are moving away. So everybody is definitely discomforted by the lacunae in the present system. But then, as I suspect, not just the diagnosis, even the clinical presentations are very different and very culture-based. So what do you think is the most appropriate way for us to go ahead as the Indian subcontinent or the population that we have? What, in your opinion, probably is an optimum way forward to better understand, better treat, better classify illnesses?
The best idea would be to look these things as symptoms and expect them to change. Start a group of medicine which would help the current symptom, but take a lifelong history, starting from pregnancy of mother to till today, and based on that progression, that trajectory, think of some medicines which would change the trajectory. For example, let's say we are treating a group of patients with psychosis. If there is a history of prodromal long phase, at risk phase, means recurrent so-called attenuated psychosis, recurrent so-called micropsychotic episode, followed by finally degenerating into a psychosis, then our one drug would be antipsychotic because that would solve the immediate problem. We should have another group of drug that would later change that trajectory. Now, what we have there, there is a so-called antidepressant which change the trajectory of psychosis. In many prodromal and high-risk psychosis patients all over the world, they have found that antidepressant delay the eventual progression to psychosis. Although it is more of a statistical question because it is very easy to see how many patients develop a disease or an outcome, but it is immensely tough to understand how many outcomes are prevented by a preventive. So it is hard, but in statistical calculation, they have found out that antidepressants has a very good, robust effect in delaying or stopping the conversion to at-risk mental state from at-risk mental state to psychosis. So, yes,
Bhaskar,
hello.
there is a question. There is a question by Ankur Singhal. He asked, "What do you think about the ancient chakra system used in psychiatry?"
Chakra system again would be similarly hard to establish and translate into modern understanding of brain. Chakra system is actually, if we think very scientifically, used to be representation of various nerve plexuses in the body. The Sahasrar is actually kind of the central sympathetic or autonomic grid. Then this here is the stellate ganglia, then cardiac plexus, then solar plexus, then hypoglossal plexus. It is actually loosely various autonomic ganglia, large scale autonomic ganglia in the body. But with that chakra system, we cannot change the phenomenology into a disease because every autonomic ganglia would be involved in every kind of brain dysfunction. So standing there, if we even say that chakra system is actually the autonomic ganglias, large scale autonomic ganglias of body, we would be powerless to translate their dysfunction into various symptoms of brain. So ancient chakra system probably would not be able to change the classification system. Well, okay, I was talking about Rasmin's question. Now the second thing is similarly, antidepressant also has changing capability of trajectory of bipolar disorder. In 2023, Lakshmi Jatham finally has published a paper which says that with antidepressant, the next mood episode, be it mania or be it depression, would be delayed in bipolar disorder. So that is a indirect evidence that antidepressants are disease modifying not only in psychosis but also in bipolar. But it is very early. We would need more evidence to put them firmly there. So this is the general state of treatment. One drug for symptom, a group of drug for changing the trajectory. this is the crudest possible scientific thing that we can do at this moment. More than that, and we would be talking into something that we don't have full understanding of. Any other question?
Yeah, if there are no more questions, I can hand it over back to the organizers for the vote of thanks.
Right. Thank you. Thank you very much, Dr. Barot, and thank you very much, Dr. Mukherjee. It was a brilliant talk, as is expected. Obviously, it was very overwhelming for many of our audience members. It was stimulating, to say the least, but more intriguing and thought-provoking. And that's the whole point of this exercise. And you of all people are quite good at throwing googlies at us and making us scratch our heads and wonder what next, right? So that's the whole point of this exercise. So thank you once again very much for making the time and stimulating us, entertaining us, and really wanting us to think out of the box, which is the most important job of any curious student, right? And it was great, Dr. Barot, that you took the time out from your busy schedule and joined us today to chair this wonderful session. And of course, to all the audience members who have been with us consistently month after month, year after year. We are in the 8th year of this program series, and all these lectures are available on the website. For the slides are available for free downloads, and the lectures are also available for free viewing. So you can revisit these wonderful lectures at your convenience time and again. And for those who have missed it, they have the opportunity to listen to them at their leisure later on. So thank you all of you for being with us. And of course, thank you to Sun Pharma for providing us with this constant support. I look forward to seeing you guys back with us next month for another wonderful chat on the training needs of postgraduate students and whatever subjects we can give justice to. So thank you all once again, and I wish you a great evening ahead. Thank you.
Thank you. Thank you, Rasman.
Thank you very much.
Bye-bye.
Bye.